Hi, it's Andrew, and welcome back to another episode of Coding Matters. Today we're going to be having an obstetrics and gynaecology focus, probably more of the gynaecological focus. And I'm delighted to be joined by Dr. Martin Ritossa, who's Divisional Director for Women's and Children's Division here at Lyell McEwen. Thanks for joining us, Martin.
Hi, Andrew.
Looking at the things we're going to cover on this session, we're going to look at making sure that there's a causal link between the diagnoses and procedures and complications that we have within gynaecology in particular. We're going to do a bit of a deeper dive into understanding what clinicians use in terms of defining and classifying utero and uterovaginal and vaginal prolapse, and comparing to that what the coders are looking for in the system that they're using. We're going to look at additional diagnoses related to labour and delivery and how to document them in a relational way. And then we're going to look at the interventions that are related to those as well. And in case you're new to coding and you're like, what is this about? So clinical coding is about taking the different clinical events, diagnoses, procedures and complications that occur within any kind of hospital encounter, but particularly those that are inpatients. And these are all distilled down into some kind of code. And in Australia, we use the ICD-10 Australian modified version for our codes. And you could say that we eventually distill down to one diagnostic related group code, and that then has a severity rating depending on the complications and the interventions that are required there. So you can see from this diagram that there is a principal diagnosis that will determine the code. Let's say, for example, pneumonia. And then there are secondary diagnoses, so they may be complications or associated conditions like type 1 respiratory failure or delirium related to that primary diagnosis. There can be procedures that are performed like a bronchoscopy, and there are comorbidities such as COPD and interstitial lung disease that would factor into the management of that pneumonia, just to put an example. But even though we'll talk a little bit about funding, because activity-based funding in Australia and many countries is based on this coding system, clinical documentation and the clinical coding associated with it is so much more than funding. It includes patient outcomes, measuring our performance as clinical units and clinicians. It's about having accurate and quality data available for research and audit. And it's about not just doctors, but midwives and nurses and allied health all contributing to quality documentation to improve the patient journey and the organisations that we work in. In case you're wondering what are the essential elements that make up a clinical code, you need to have a specific kind of assessment, some elements of history, exam or results from investigations, one or more of those, some kind of diagnostic statement or clinical impression that uses diagnostic terminology and is specific, and then some kind of intervention or plan. And that can be as simple as monitoring. So if there was anemia with a blood result, so the blood result would be the data stating that it's anemia and its cause would be the assessment. And then even if it is repeating a blood test tomorrow to monitor that anemia, you are showing some kind of intervention for that diagnosis. So let's get a bit more specific within the ONG realm. And we're going to talk a little bit about hysteroscopy initially, and about linking the diagnosis and the symptoms or signs that led to this investigation with that diagnosis and interventions. And this is a really common area that a lot of clinicians are missing out on, is actually saying, this is the diagnosis, this is the procedure, and this is why we did it, and potentially a plan of what's going to happen further from this. So in this example, we've got a patient admitted for investigation of heavy menstrual bleeding. Would this be a pretty common referral to your department?
A very common referral.
Very common. And then coders can't necessarily go, because there was heavy menstrual bleeding and you did a diagnostic hysteroscopy, that therefore those things are linked. It seems really obvious and straightforward that to us as clinicians, those are those two things. Why would they not be linked? But we simply need to make a statement which is usually due to. So the patient is having a diagnostic hysteroscopy due to heavy menstrual bleeding, and ideally after the procedure, you actually document what the findings were, and specifically if you found findings consistent with a diagnosis, and then you could state that there was heavy menstrual bleeding due to fibroids or something similar, I imagine. So we need to have that causal relationship, that causal link. It needs to be things like due to or secondary to. It can't be in the setting of, in the background of. Those things don't actually specify a direct relationship between those. So they're the examples there. What are the likely causes that you might find with a hysteroscopy related to bleeding, Martin?
Well, as you already said, Andrew, fibroids would be one. Mm-hmm. Also, polyps within the endometrium. And it could also be due to the whole list of conditions listed under the CALHN criteria, which I'm sure all your audience are well
Forgive-
aware of.
Forgive my ignorance.
I'll
Palm-
need to
So palm Cohen is specifically menstrual bleeding causes?
heavy menstrual bleeding causes. Yep.
Okay.
So,
So that's handy because that's I suppose, a clinical tool that your unit and discipline would use, and then we can relate that to a diagnostic statement that the coders can then use as well.
so they can look at the heavy menstrual bleeding. The hysteroscopy found this cause as listed in the palm Cohen
Absolutely.
classification.
And would you say that you always find a cause on hysteroscopy, or do you sometimes come out with some inconclusive or just suspicious features?
Certainly, a lot of it would be inconclusive. Yes, the cause not found.
Yeah. So when we, that's a really common area. Lots of different disciplines find that an investigation, even invasive one, doesn't always give you the full answer, but sometimes it can give you hints towards it, or can be findings suggestive of a certain diagnosis. Unfortunately, within documentation and coding, we can express a degree of diagnostic uncertainty, and it still gets to be coded. And the example I use most commonly in this is dementia is a diagnosis that needs to be made over many months. But so you can't necessarily see someone as an inpatient and say this person definitely has dementia. They should be ideally seen by a physician or geriatrician or memory specialist over a period of some time, and then get the full picture and say this person had dementia. But you could, on one particular visit, say this person has likely dementia, they have probable dementia, they have suspected dementia. That still is able to be coded and represent the investigative process that's going on to come to that conclusion. But you can still kind of express that diagnostic uncertainty. And I think that's a really handy tool in all areas where you're investigating bleeding and pain and other things like that. One test may not, or even a series of tests, may not necessarily come up with a conclusive diagnosis, but you can still express that and say the heavy menstrual bleeding was likely due to fibroids or likely due to other pathology. And there may be more than one pathology. Would you say that some people have multiple causes?
Quite possibly, yeah.
Yeah, and so we can express that. You don't need to limit yourself to one. You can, and please avoid saying multifactorial without listing the factors that are there, because that can't be coded. The more specific we can get to, even if there's a degree of uncertainty, that's okay, as long as we document it. Let's talk a little bit more about prolapse. I've heard that between the clinicians and the coders, this is a bit of a hot topic and often a source of confusion or sometimes disagreement, because the systems that we're using as frontline clinicians are different to the system that the ICD-10 is dictating the coding to use. Is that right, Martin?
Yeah, I believe the ICD-10 is based on the WHO sort of classifications, and they're quite dated now.
Sure.
And times have moved on.
Yep.
And other classifications are used for prolapse classification and for research purposes that are very important, but unfortunately they can't be used to code the patients.
Okay. So when you're looking at, I suppose we've got pelvic prolapse, I'm told that's a term that we sometimes use, but from a coding perspective is not specific enough because it hasn't named an organ. Is that about right?
Yeah, and look, pelvic organ prolapse doesn't describe what's happening, and is not a very useful term for anyone.
Yeah.
Not even the case notes. What you don't know what's going on. It needs to be defined more than that for clinical reasons, more than anything else.
So what would be the common ones that you would move from pelvic or pelvic organ? What would we like to use instead?
Well, we'd probably use the words anterior wall prolapse, or posterior wall prolapse, or uterine prolapse.
Yep, and then sometimes combinations like utero-vaginal prolapse as well, depending on the situation.
If it was both, yep.
Yep. And I suppose that's the diagnostic part, and then we can grade severity or help classify it further. Certainly there was gradings and stagings, and I'm told you now use a POP-Q classification.
We do. It's a quantitative system that looks at the descent above or below the introitus measured in centimetres.
Yep, okay. But I'm told that from a coding perspective, POP-Q isn't able to translate directly into what we're using from the WHO ICD-10. They are looking for terms like incomplete or second degree or complete prolapse, and it's difficult to marry those two classifications together. And so we probably need to, each unit needs to work out what are we defining as complete and incomplete, use that language so that we can at least code it properly, even if you're also using more contemporary systems like POP-Q. Would that be the approach you'd recommend?
I think that's a very sensible approach, yeah. We do have a term, it's an old-fashioned term, complete procedentia, which describes when the uterus is completely prolapsed. Hopefully we don't see that too often.
No.
But that would be one definition, but I think what you're suggesting, coming up with a definition within your unit would be very good.
Yeah, because it sounds like otherwise the incomplete could almost be everything that's not complete.
Correct.
And there may be some things of more severe that you would still put under that complete, but you would be able to add more nuance with the POPQ or other systems. And then in terms of cystocele, rectocele, these are very diagnostic terms. We should be using them and looking at the relationship between those and prolapse, is that right?
Yeah, I mean, again, they're old terms describing what's behind the prolapse, and we don't really know what's behind the prolapse. We'd probably prefer to use the terms anterior and posterior to describe it.
All right.
Rather than those terms. But those terms are able to be coded cystocele and rectocele, so they can be used for coding purposes.
Excellent. So any of these things that we can put due to, secondary to, and even more than that, you can often have one or more factors or other diagnoses that are contributing to that prolapse. I suppose like obesity or other procedures that have been performed before or related to other deliveries. Are there other things that can contribute that you could document and say that these are the factors that have led to?
So obesity and childbirth would probably be the two main factors that would lead to it, yes.
Yeah, so sometimes we assume those things, but if we write them, they can add to the complexity and accurately code what we're doing.
I guess chronic cough, smoking would be other things that would contribute to it.
Wouldn't have thought of that. Yeah, okay, that's handy to know. So let's look at an example now. You can see in this example, we've got a 50-year-old patient admitted for pelvic floor prolapse, history of previous hysterectomy, not uncommon. There was a repair of cystocele and suspension of vaginal vault via vaginal approach under a GA. That's pretty standard kind of stuff that you do. Patient was consulted for persistent low blood pressure. This was diagnosed as hypotension. Notice the clinical data, then the clinical assessment there, and then the plan was IV fluid. So on a standard minor, that would give you a minor complexity for that particular diagnosis-related group, and you would get, as of this year, about $8,000. Interestingly, if you were to use the term vaginal vault instead of pelvic floor prolapse, noticing that pelvic floor versus vaginal vault, more specific terminology that's used, that will then be related to, I think, a different diagnosis-related group, and the same complication of hypotension and given fluids, we'll put that into a major category of complexity and get almost $14,000 of funding. And really that's probably, that $14,000 is much more representative of the time and resources that your team has invested in that person's recovery. Would that be about right?
Oh, certainly, and the prolapse you described is a complex one to repair as well. So it needs to be documented.
Yeah, so you can see here that this example of documentation, if we had just called it pelvic floor, really our department is getting underfunded or under reimbursed for the investment in that person's care, and by just small improvements of the terminology that we're using through exactly the same procedure for exactly the same indication with exactly the same complications, the funding is closer to the actual time and resources invested in that patient. And as a manager, that's pretty important, you'd say?
Oh, I think for everyone it's pretty important. You know, we need staff, we need equipment. The more money we can get funded, the better.
Yeah, absolutely. We've got now some terms along that line of diagnostic terminology that we're using, and trying to avoid inferences and assumptions that we often do and get down to really specific, even if it's short, terminology. So you can see examples on the left-hand side here. Blood pressure of 80 on 40. That would raise my blood pressure, probably yours as well, Martin. That would be like when you're suspicious of what could be causing that, our mind will jump to how do we intervene. We're trained for that.
I'm a surgeon, so they're bleeding.
They're bleeding every time.
Every time.
And as a physician, I assume they're septic and get the antibiotics on. And it could be a bit of both. Why not?
Yes.
Why not?
Yep.
So we see that, we infer hypotension, but a coder cannot code that. So we just need to simply write hypotension. We've got the clinical data, hypotension, and then the intervention that occurs. We can see here another one, delivery affected by difficult shoulders. To me, that kind of makes sense, but it's more a description of what happened rather than a diagnostic term, as opposed to a Roberts maneuver due to shoulder dystocia. I'm not an expert in this area, but that sounds a lot more specific.
Or it's describing what you did.
Yep.
And it needs to be documented for medical legal reasons as well. So you need to be specific in these particularly more complex cases.
Absolutely. As a haematologist and as a gynaecologist, we are both very passionate about iron deficiency anemia, would you say, Martin?
Absolutely.
Absolutely, love it. We love a good iron infusion and iron supplementation. So you can see here an example where the hemoglobin is 85, MCV is low. You and I are already thinking iron deficiency anemia, but sometimes we jump from that result to giving iron and we never state it. So just simply saying even if we haven't got an iron studies, you might say likely iron deficiency anemia. Order iron studies, arrange for iron infusion, that kind of management. Really simple, but very, very clear. It doesn't take a lot of extra. And there's some as well where we've got some estimated blood loss that's listed here under vaginal or cesarean, and there's a certain number that's put onto that. The estimated blood loss is really helpful to quantify, but it isn't a diagnostic term in itself. And so writing postpartum hemorrhage with estimated blood loss of greater than 500 mils, that can be coded and that data can be captured, and that's really important for your measuring your kind of clinical performance of your unit, right? Let's move now into the obstetric realm, and we've got here a summary slide that looks at a number of common areas that are coding queries. So they're areas that clinicians are perhaps not as clear and specific in their documentation, the relationships there that we can do a bit better with. So induction of labour, pretty common procedure within your unit. Sometimes we're not actually specifying or putting a diagnostic statement as to why we chose to go to an induction of labour. What would you see as the common reasons someone would and therefore need to document related to induction of labour?
Firstly, I think this is a real hotspot, and it's very common not to write the indication.
Just happens, you're in the moment.
And we're actually trying to maintain the levels of inductions of labour, so it's very important to know what the reason is. So it's critical. I mean, the reasons vary from what we call post-dates, which is at 41 weeks. We don't want people going beyond post-dates for risk to the fetus. That's probably the most common reason, but they can be induced for a whole lot of other reasons, like diabetes, premature rupture of membranes. There's a whole host of reasons.
So there could have been like a kind of obstetric event that has required us to quickly move to induction labour, or there might be a concurrent medical condition like gestational diabetes or development. Some people develop cancer that's identified during pregnancy, and so we might...
Preeclampsia, which is very common, which is an obstetric condition.
So just being really clear and saying we're having induction of labour due to development of preeclampsia, due to uncontrollable gestational diabetes or whatever the issue is, that relationship there, just due to, secondary to, allows us to capture that data and understand better what our patients are going through and the reasons why our clinicians are choosing to go induction of labour. There's a common theme as well about attributing other quite common conditions like hypertension, like diabetes, whether it's attributable to the pregnancy or whether it's exacerbated and it's already there before. So we've got examples here of pregnancy-induced hypertension, PIH. I've never heard of that acronym before, but we love acronyms. And if someone already has hypertension and it's exacerbated by pregnancy, that's a different code. And so we need to indicate that. And sometimes it might later turn out to be that they probably did have hypertension, but we just didn't know. But we can know that later. But if this is the first time that hypertension's ever been identified, we'd assume that it is pregnancy-induced and need to document that.
Or in fact, preeclampsia is very common and it's probably preeclampsia.
Is it just hypertension, or is it part of a bigger picture of something more serious? That's a really good point. And then same thing with diabetes. A lot of women develop gestational diabetes during pregnancy and they don't actually have type 2 diabetes in the background, but others do have type 2 diabetes and they're just exacerbated by the pregnancy. So being really clear about what the relationship is and then what we're doing about that hypertension, what kind of the management is of that. Another common one would be cholestasis. Understand some people can have gallstones and they happen to get cholestasis during pregnancy, and so being clear that that is not specifically induced by the pregnancy, as opposed to pregnancy-related cholestasis, which is technically intrahepatic cholestasis of pregnancy. That would be a common thing that we would see.
I wouldn't say it was common. Uncommon.
Yeah.
But common enough that we see it from time to time, and also something that we have to be very careful about because it can have unexpected stillbirths. Right?
Absolutely. And in terms of preeclampsia, how would you like your clinicians to be documenting the preeclampsia?
It's clearly possible, obviously. I mean, you can't, quite often we just rely on a blood test and everyone assumes that the blood test results mean they have preeclampsia, but unless you've documented it correctly in the notes, hypertension due to preeclampsia, we won't get the funding that we need. Yeah.
So, I mean, obviously hypertension is one of the most common manifestations, but also whether there's liver derangement that could be attributable to preeclampsia, and whether we're thinking this is mild that we need to monitor, or whether this is severe and we need to intervene quickly.
So you have HELLP syndrome, which can be quite severe. So you've got the hemolysis and the low platelets. And,
hematologists are very interested in that kind of thing.
which can be important. So it's very important that that's documented clearly.
Yeah.
And again, what's the cause?
Absolutely.
Yeah, help syndrome due to preeclampsia.
So failure to progress is an issue that is commonly managed by the obstetric team. I'm told that just failure to progress alone cannot be coded. So that's a challenge where we're not going to be able to gather data and get appropriate funding for our services if we're missing out on that opportunity. So there's another terms that we can use. A lot of terms, unfortunately, just because we're limited by the system, the ICD-10 that we use, they're things like uterine inertia. Even as a student, I don't remember this term ever. It's not a term that you commonly use. Is that right, Martin?
No, we've moved on.
Moved on, yeah. So we can use the term failure to progress as long as we specify which stage of labour that it's in. Is that your understanding too, Martin?
Yeah, so you classify it as failure to progress in the first stage or failure to progress in the second stage.
Are there other potential diagnoses or conditions that would factor in or contribute to the failure to progress that are worthwhile documenting?
Yes, there are other terms. So terms like incoordinate contractions, poor contractions can all be used as well.
Yep.
And then we have obstructed labour. That would probably be used later in the second stage or even the third stage, but clearly documenting that there's the obstruction. Yep.
That's good. So they're kind of descriptive but are also diagnostic terms in themselves. Very good. So we've moved on from failure to progress, and during delivery there can be a lot of events and interventions in order to bring about the safest and smoothest possible delivery of the child. And the appropriate documentation of that, obviously challenging because these things can happen very quickly, and skilled practitioners will make appropriate, accurate and quick decisions and have to document these things in retrospect. So some of the terms that we can use and the equipment that we use, it's really important to just save that to your memory and be able to put that quickly down to page, or if you have acronym expansions or smart text within your electronic medical record, you might be able to use some of them to prompt you to fill in those details. What are the common things that we should be documenting but perhaps sometimes we're missing, Martin?
Well, certainly if you do a forceps delivery, for example, or even a ventouse delivery, you should describe the instrument you use. So you would say Neville Barnes forceps, CALHN's forceps, although we don't tend to use them very often these days, or Wrigley's forceps, lift-out forceps.
Yep.
So just to use those terms, which it sounds like, why are we doing that for coding purposes, but certainly for medical and medico-legal purposes, is very, very important anyway.
Yep.
So the more you can write about how you deliver the baby, you're going to think that's very important in 10 years' time when the lawyer's letter arrives on your desk.
Yeah, for sure. Probably a particularly important emphasis in your field than some others. And always with that relationship, like we talked about before, the reasons behind the selection of that particular instrument, the reasons behind moving to a caesarean section, sometimes they get missed, and that's a missed opportunity to understand the patient journeys that we see and the decision making of our clinicians. Is that an area that we could really improve on more? Yeah,
absolutely, and it's frustrating because we look through these cases obviously in our morbidity and mortality meetings, and you're trying to review things and you say, well, it doesn't tell us why did they do that?
Why
did they go to theatre? It's not clear in the notes. So again, it's a practical thing, but it's also a very important thing from a medical point of view.
Yeah, and even from that, there's that whole idea of how can we learn from our experiences. And if we aren't able to examine the process because the process wasn't documented and the rationale was not documented, we can't then learn as a team and as a unit and even as a network from things that went well, but also things that didn't go as expected. And that's such an important part of quality improvement, is understanding that journey and the process and the thinking behind that.
So you're doing an operation, your caesarean section should take you about 45 minutes, maybe 30 minutes if you're really slick.
Yep.
But if it takes an hour, how do we quantify that? But if you've written in the operation report that there were adhesions there that you had to deal with during the operation, well, you've explained it, and that can be coded as well. Absolutely.
And even decisions around what kind of antibiotics may or may not have been used, or other pharmacotherapy, just simply putting the reason, benzylpenicillin given due to GBS risk or other things that you might then encounter. So after delivery, a common complication, fortunately not too common, is postpartum hemorrhage, or hemorrhage that's during delivery, and the anemia that's related to that. We often write hemorrhage but maybe don't write the anemia part. So ideally documenting the postpartum hemorrhage and the likely reasons or contributors behind that. There may be other associated conditions like atonic uterus or adherent placenta. or if it's related to particular intervention, bleeding from, hopefully not a lot of bleeding from an episiotomy, but from a caesarean section as well, if you have a higher amount of bleeding, and being able to document that as being part of a postpartum hemorrhage as well, that's important. And what you're doing about that. So are we measuring that if we've got a hemoglobin level pre and post and the next day, and are we investigating other management like a transfusion or an iron infusion to manage that? Are there other tips that you'd recommend in terms of documenting?
The volume as well, so
volume
that can actually be listed. That's good.
Yeah. Are there categories, or as much as the estimate you can?
Well, 500 mils is the volume for blood that's not a postpartum hemorrhage. Okay. Above that, it is.
Yep.
If it's more than 1,000 mils, then it becomes would classify as a severe incident, something we want to look into. So
yeah.
So the volume is very important.
Okay, so the volume there would really factor into that's clinical data and a diagnostic statement saying like a major or a minor postpartum hemorrhage related to that. So here's an example. We've got a 23-year-old female that's admitted and had an induction of labour for gestational age and gestational diabetes. Notice that we've linked clearly the relationship of the induction of labour and the indication diagnosis related to that. There was then failure to progress. We haven't listed why there was failure to progress or put a stage to that. There was a decision for a caesarean section under spinal anaesthesia. There was blood loss estimated at 800 mils. Great to quantify that. Oxytocin was given, and the patient was given an iron infusion prior to discharge. So that would put into an intermediate complexity with a remuneration of about $10,000. Let's just slightly tweak that to make it more accurate related to this particular presentation. So here, same introductory statement, same diagnosis. We put a link to why they had an induction of labour. Then we put failure to progress due to obstructive labour. So there's a specific reason why they failed to progress. We've gone to the caesarean. We've got the estimated blood loss. We've added a diagnostic statement of postpartum hemorrhage instead of just the blood loss. And then we've given an iron infusion and again put a condition to that due to acute blood loss anemia. So that's become just a little bit more specific. Really, someone writing that, it's going to add an extra 5 to 10 seconds. And that's added about a bit over $7,000. And that $17,500 is much more reflective of the resources and intensive care that this person has received as part of their delivery. Would you say, Martin?
Absolutely. Very important. And it's good documentation as well. Good
documentation. Small improvements can go a long way. Here's a similar one, but just with some different examples. So this was also failure to progress, caesarean section of the spinal, 281 mils of autologous blood transfusion received, estimated blood loss of 900 mils, similar to the last one, and iron infusion. So here again, we specified a relationship and a cause of the failure to progression from obstructed labour. We've then also added postpartum hemorrhage documented due to bleeding from caesarean incision, and then we've put the iron infusion due to acute blood loss anemia. So just more of that diagnostic terminology there, and again, an uplift of about $7,000, much more accurate for that patient. Here's a few examples, just briefly, that are kind of highlighting how small changes to the documentation, which we've highlighted in bold, adding those diagnostic statements, adding the due to, the causal relationship between an intervention or an event and the cause of that underlying, will make a big difference in terms of funding there. So in summary, we've gone over a lot of gynecological conditions, and we've specified putting a causal link of why did you do that particular intervention or investigation, and documenting the findings, being able to express a degree of diagnostic uncertainty through terms like probable or suspected or likely. We try and get as specific as we can to make sure that there's that clinical data, that diagnostic statement or terminology, and a plan that will then make an accurate code. And then we've looked at around labour and delivery and postpartum complications, and how we can add quality through just more specific and relational terms. Doesn't take a lot of effort, but makes a really big difference to the way we measure our performance, learn from patient journeys, and obviously get remunerated as well. Thanks for joining me, Martin. Any particular closing tips or comments?
Look, I think if you make this a habit, particularly early in your career, it'll just become automatic.
Absolutely.
And it won't take any time at all.
Yep.
And it'll just be your practice. And I think the one thing that frustrates us as senior clinicians going back and looking at things that haven't gone quite as well as they could have is the lack of documentation. So great documentation gets good patient outcomes, GPs knowing what's going on, and the coding all flows.
Yeah, absolutely. Completely agree with that. I think the stitch in time saves 9. a good document that's been just taken that extra minute or two to write well and clearly can really save a lot, hours and hours of time in the future, and can also make sure that our units are getting appropriately funding for the care they're providing. Thanks for watching.